Scott Brown's Rhinology, Chapter 87, Anatomy of the Nose and Paranasal Sinuses. We are going to deal with external nose. External nose. Skin and muscles of the external nose. The thickness of the skin and soft tissues of the nasal bridge vary according to individual skin type and anatomical location. Over the dorsum and the sides of the nose, the nasal skin is thin and loosely adherent to the underlying framework. The nasal skin becomes thicker and more adherent towards the nasal tip and alar cartilages, where it contains numerous sebaceous glands. The elasticity and mobility of the skin over the nose also varies according to the quality of the collagen fibers anchoring the skin to the underlying structures. The extension of the facial SMAS, the subcutaneous musculo-aponeurotic system layer, continues over the nose as numerous muscles of the external nose which function to compress, dilate, depress and elevate the nostrils and nasal tip. These muscles are all supplied by branches of the facial nerve. The nasal elevators include the procerus, levator labii superioris, alicule nasi, and anomalous nasi muscles. The depressors include the alar nasalis and depressor septi nasi muscles. Compressor muscles include the transverse nasalis and compressor narium minor. The dilator nasaris anterior muscle acts as minor dilator. The subcutaneous tissue of the nose is made up of 4 layers: superficial fatty, fibromuscular, deep fatty, and periosteal layers. The superficial fatty layer is directly connected to the dermis. The fibromuscular layer comprises the nasal SMAS, subcutaneous musculo-aponeurotic system. The deep fatty layer lies deep to the SMAS and contains the neurovascular system. The deepest layer is the periosteum and perichondrium. During external approach rhinoplasty, dissection deep to the third layer minimizes post-operative scarring and retraction because of the neurovascular and SMAS structures are preserved. Box 87.4, dissection deep to the third layer of the nose, that is deep fatty layer, minimizes post-operative scarring and retraction because of the neurovascular and SMAS structures are preserved. Vestibule. The nasal vestibule is the anterior most aspect of the nasal cavity and serves as the entry point from the external nares into the nasal cavity. The vestibule is demarcated by the limen nasi, located at the caudal border of the lower lateral cartilage. The limen nasi is the location where the marginal incision is made during external approach rhinoplasty. It is lined by keratinizing stratified squamous epithelium and coarse hairs called vibrissae, sebaceous glands, and sweat glands. A layer of mucus typically covers the outer surface of the vibrissae, which functions to filter airborne particles during inspiration. It is important to note that only a small part of the alar rim is composed of cartilage. From the lateral crust, the majority is composed of fibrofatty tissue. Nasal cartilages. While much focus is placed on the internal septum and turbinate anatomy, the anterior third of the nasal passage has a critical functional role and can greatly influence nasal airflow. The nasal cartilages consist of hyaline cartilage that attach to the bones of the anterior nasal aperture to form the skeletal framework of the external nose. These cartilages include the upper and lower lateral cartilages, septum and sesamoid complex. The lower lateral cartilage is divided into medial, intermediate, and lateral crusts to form the natural act of the nasal alar. The upper lateral cartilages are trapezoid-shaped cartilages that attach to the dorsal aspect in the midline, nasal bones cranially at the rhinon, and lower lateral cartilages caudally via the scroll area. The relationship and the architecture of these cartilages form the external and internal nasal valves, which are critical to the nasal airflow. The external nasal valve is comprised of the nasal septum medially, alar rim, lateral crest, sesamoid complex, and fibrofatty tissue laterally, and nasal sill inferiorly. Anatomically, abnormalities or compromise in the structural integrity of these components can cause external valve narrowing, stenosis, or dynamic valve collapse that is exacerbated during inspiration. The internal nasal valve in normal development is the narrowest portion of the nasal cavity and is bounded by the septum medially, caudal edge of the upper lateral cartilage, and head of the inferior turbinate laterally, and nasal floor inferiorly. The apex of the internal nasal valve is approximately 10 to 15 degrees in Caucasians and wider in non-Caucasian populations. Changes in the relationship of any structure within the space can cause symptoms of nasal obstruction. Box 87 nasal valves. Figure 87.8 nasal valves. A is the midline sagittal CT with green line indicating the relative position of the external E and internal I valves. B is endoscopic view of the left external nasal valve including 1 septum, 2 alar rim, comprised of lower lateral crest, sesamoid complex, and fibrofatty tissue, and 3 nasal cell. C is the endoscopic view of the left internal nasal valve including 1 septum, 2 caudal edge of upper lateral cartilage, and 3 head of inferior turbinate. The structures of the external and internal nasal valve are critical to nasal airflow, with the internal nasal valve representing the narrowest portion of the nasal cavity. The internal nasal valve is bounded by the septum medially, caudal edge of the upper lateral cartilage, and head of the inferior turbinate laterally, and nasal floor inferiorly. Key points: the upper lip and nose are considered the danger areas of the face because infections in this region may be transmitted in a retrograde fashion through a valveless venous system to the cavernous sinus. Blood supply. Arterial supply to the external nose has both external and internal carotid artery contributions. Branches of the facial artery supply the alar region and include the angular and superior labial arteries. The angular artery and its lateral nasal branch supply the nasal side wall and alar. The superior labial artery gives rise to a columnar branch that supplies the nasal cell and columella, and a septal branch that supplies the anterior nasal septum. The ophthalmic artery gives rise to a dorsal nasal branch which anastomoses with the lateral nasal branch of the angular artery to supply the dorsum and the nasal side wall. The nasal dorsum and the nasal side wall also receive vascular supply from the external nasal branch of the anterior ethmoid artery and infraorbital artery, respectively. There are rich anastomosis between these vessels on each side and between right and left sides of the nose. Venous networks. The venous networks do not parallel the arterial supply but correspond to territories termed arteriovenous units. The frontomedian area drains to the facial vein and orbitopalpebral area drains to ophthalmic vein. The facial vein originates as the angular vein located at the inner canthus. The angular vein forms as the confluence of the supratrochlear and supraorbital veins. The upper lip and the nose are considered the danger areas of the face because infections in this region may be transmitted in a retrograde fashion intracranially to the cavernous sinus. This phenomenon can occur because of the facial vein communicates through a valveless venous system within the cavernous sinus via the ophthalmic vein. Nerve supply. A working knowledge of the neural supply to the external nose has clinical value while performing a nerve block to this region during procedures such as rhinoplasty or closed reduction of nasal fractures. The supratrochlear and infratrochlear branches of the ophthalmic nerve supply the skin of the nasal root, bridge, and upper portion of the side walls of the nose. The infraorbital branch of the maxillary nerve supplies the remaining skin of the nasal side wall. The external nasal branch of the anterior ethmoidal nerve exits between the nasal bone and the upper lateral cartilage to supply the skin over the dorsum and the nasal tip. Figure 87.9, external nasal innervation. A is the supratrochlear nerve, B is the infratrochlear nerve, C is the anterior ethmoid nerve, D is the infraorbital nerve. Lymphatic drainage. The lymphatic drainage of the external nose is directed towards the submandibular, submental, and facial nodes. Drainage of the external nose is often bilateral and drain to the parotid region may be possible. Nasal cavity. The nasal cavity extends from the external nares to the posterior choana, where it becomes continuous with the nasopharynx. The nasal cavity is divided into two passageways by the nasal septum. Each side consists of roof, floor, lateral and medial, the septal wall. The nasal floor is concave from side to side, flat, anterior posterior, and horizontally oriented. The anterior three quarters are comprised of the palatine process of the maxilla and posterior 1/3 by the horizontal process of the palatine bone. Approximately 12 mm behind the anterior aspect of the nasal floor is the slight depression which corresponds to the incisive canal. The incisive canal contains terminal branches of the nasopalatine nerve and greater palatine artery. The roof of the nasal cavity is formed by the skull base and slopes downwards anterior posteriorly. This is important to recognize during endoscopic sinus surgery as dissection progresses posteriorly towards the sphenoid sinus. The superior aspect of the nasal cavity include the superior septum, superior turbinate, and upper aspect of the middle turbinate is lined by olfactory epithelium. With the exception of the vestibule, the remainder of the nasal cavity is lined by respiratory epithelium. The respiratory epithelium of the nasal cavity is continuous with the mucosal lining of the entire upper and lower airway system. Three different types of epithelium within the nasal cavity consist of squamous, nasal vestibule, olfactory, superior septum, superior turbinate, and upper aspect of the middle turbinate, and respiratory remainder of the nasal cavity epithelium. Nerve supply. Innervation of the nasal mucosa includes both autonomic and sensory components. The autonomic nervous system regulates the degree of vascular tone, turbinate congestion, and nasal secretions present in the nose. Nasal secretion is regulated by the parasympathetic nervous system. Presynaptic parasympathetic nerve fibers travel along the median nerve. Contribution from the greater superficial petrosal parasympathetic and deep petrosal sympathetic nerves and synapse within the sphenopalatine ganglion to innervate the nasal mucosa via postsynaptic fibers. Vascular tone and turbinate congestion is regulated by the sympathetic nervous system. Postsynaptic sympathetic fibers pass through the sphenopalatine ganglion and terminate in the nasal mucosa. The ophthalmic and maxillary division of the trigeminal nerve provides the sensory innervation to the nasal mucosa. Trigeminal nerve fibers also pass through the sphenopalatine ganglion and transmit sensations of pain, temperature, and touch. The lateral wall of nose and turbinates are supplied by posterolateral nasal nerves from V2 arising from the sphenopalatine foramen and ethmoid nerves arising from V1. Although an artery supplies the inferior turbinate posteriorly, the neural innervation is from the lateral walls nerves continuing caudally. Box 87.7. The parasympathetic nerves regulate the nasal secretions, sympathetic nerve regulates vascular tone and turbinate congestion, and trigeminal nerve controls the nasal cavity sensation. Thank you.